This is the Psychedelic Medicine podcast.
Hello and welcome to the next episode of the Psychedelic Medicine podcast. I'm Dr. Lynn Marie Morsky, your guide in this journey, and today we'll be discussing managing medical risk for patients seeking psilocybin therapy with Dr. Reid Robison. Dr. Robison is a board-certified psychiatrist and chief clinical officer at Numinous, overseeing the company's psychedelic and mental health services across the U.S. and Canada. He has led over 200 clinical trials in neuropsychiatry, including the MAPS-sponsored MDMA-assisted therapy study of eating disorders and several other psychedelic studies with psilocybin, LSD, and DMT. I'm very excited to get to our conversation with Dr. Robison. But before we do so, just a reminder that the Psychedelic Medicine podcast is for educational and informational purposes only. Nothing here is to be construed as medical or legal advice. And as you know, this is where I generally throw in an advertisement for the Psychedelic Medicine Association. Well, today you're getting the Uber advertisement because Dr. Robison is one of our board members. So proud to have him on the board since day one. And if you don't know from listening to this podcast, the Psychedelic Medicine Association, our mission is to educate frontline healthcare workers from therapists, doctors, nurse practitioners, anybody that a patient might go to and say, I'm struggling with anxiety, depression, cluster headaches, any of the things that we know psychedelics are being investigated for. We want those clinicians to be ready to have conversations with their patients about psychedelics when a psychedelic option may be appropriate. So if you are interested in learning more, please check out the Psychedelic Medicine Association at psychedelicmedicineassociation.org. Now, not uncoincidentally, what I have Dr. Robison on to talk about today is the subject of the Psychedelic Medicine Association's first ever CME/CE accredited course called Managing Medical Risk for Patients Seeking Psilocybin Therapy. So let's get into it. Thank you so much for joining us today, Reid.
Happy to be here. And it's exciting that this is a CE course. It shows how psychedelic medicine is really, growing up and starting to enter everyday healthcare. So I'm excited to chat.
Likewise. And yeah, that was really important to us because we know clinicians' time is valuable. And if they are going to sit down and take the time to learn about this new burgeoning area of medicine, and by the way, when we say new, we just mean as it's working its way into the medical mainstream. We know these medicines are old, but we want to make sure that they get the credit for that time. And so we wanted to make sure that it was CME and CE accredited so that, and also so there's an extra incentive because clinicians have a lot on their plates. A lot of new things pop up every day. It may just be like, which thing should I learn about next? And we wanted to really stress, like, look, this is an important thing, especially for the physicians that may be in a place like Oregon, where patients are going to start asking, hey, doc, I hear this thing is legal. Can I do this psilocybin therapy? We very often just kind of focus on the people who have maybe just one diagnosis. Oh, I'm otherwise healthy. I just have depression. But that's not the case for a lot of patients. And so, Reid, if you could talk about, as a physician yourself, some of the things that when you're doing, I guess, before we get into psilocybin generally, just to let audience members know, because we have a lot of people out there that aren't clinicians, just a little bit more about what like a clearance is or what medical risk stratification is, those kinds of things. When somebody is about to undergo anything. So right now we're talking about psilocybin therapy, but patients have to undergo clearance to undergo surgery or do other types of things. So if you could talk a little bit about what that entails.
Sure. And just as far as kind of the big picture goes, I get asked questions on medical considerations with psilocybin from a few different angles, right? As you mentioned, I've been doing clinical trials with psilocybin and other compounds for a while. We're currently working on the Compass study. We participated in the USONA study. So that's the very kind of rigorous version of medical screening, using the inclusion-exclusion criteria of the study, screening out most other things, medical conditions and meds. But practically speaking, another way questions come, and this is quite often, are from people interested in seeking out psilocybin experiences on their own, whether it's here through a church, a religious exemption, underground, or going overseas to a retreat. And in fact, earlier this year with my colleague Steve Thayer and Neil Barkley as well with Numinous, we took a bunch of people out to Jamaica for a psilocybin retreat and did a medical screening on everyone. So it's proving to be quite practical knowledge now, even though psilocybin is still under this fast track designation under FDA clinical trials. But as we know, people are asking about it on a daily basis in mental health clinics and in the psychedelic community.
And so, like this clearance that you're talking about, this often involves both psychiatric, like the mental health, and the physical health aspects, correct?
Yeah, because the risks fall into both categories. Like I view it as pretty similar to clearing someone for a course of ketamine therapy. Similar process, different considerations, of course, because a classic psychedelic will have, a different mechanism and different things to pay attention to with some overlap. But example of the categories in both would be you want to know someone's cardiovascular health status and history for both medications, because there may be a transient increase in heart rate and blood pressure during, right? You got to be able to handle a little bump in that, make sure things are controlled and there are no surprises going into it. And then an example of the psychological mental health category would be like history of psychosis or mania, that the fear is, based on some preliminary evidence, that psychedelic medicines, psilocybin included, could exacerbate or precipitate an episode of prolonged psychosis, delusions, even some manic symptoms in people at risk.
Yeah, and I guess that last part is the key: people at risk. And so, right now, I think as an a scientific field, everybody is still trying to figure out what exactly does put a person at risk for an adverse outcome with psilocybin. We know, on the whole, as far as the psychedelics go, psilocybin is one of the most safe. However, that does not mean that there are still not risks. So, can you talk a little bit about how we are able to, or like even for this course, how you were able to put some kind of guidelines when we're still trying to determine what the risk is?
Yeah, and it's like everything in medicine, it's a moving target, an evolution, I guess, if you will, where studies with psychedelics, the clinical trials initially would screen out really conservatively, like anyone with a first degree relative with a family history of psychosis, not eligible. And then, of course, as things enter the clinical world, like they have with ketamine, like they are with psilocybin in Oregon, right? And like other countries are doing with retreats in a solid and medically screened way. That's when we get real world people involved who may have medications on board or conditions to consider, or a real history of like a manic episode 10 years ago and nothing since. What do you do with that? So that's when um, people's guidelines, screening practices ended up a little more lax than clinical trials, but still conservative, like allowing people with a first degree relative with psychosis to come in if they've never had a history themselves, and then up to clinician judgment on some of the finer points of distant, isolated episodes with or without an explanation. But I think, to answer your question, it's we are learning more and more about risk stratification, and there's a long way to go. These guidelines will look different in 10 years, just like they do after a new drug comes to market and there's some post-marketing surveillance at scale looking at the incidence of potentially rare events, or getting a more clear picture of how common things show up in a real world setting.
Yeah, absolutely. I always think about the fact that, having bipolar disorder was an exclusion criteria for, I think, most of the studies, but now I believe it's UCSF is studying psilocybin in those with bipolar disorder. And so when that result comes out, then if it maintains, oh yeah, they did not do well, then we continue to put that on the exclusion criteria. And if they do well, then that's when, like you said, that there's an evolution and we now have this new piece of data and we can decide, okay, now we can evolve what we thought was an exclusionary criteria.
Yeah, yeah. To give a couple examples, like in psilocybin, the question comes up a lot: what happens if you're on an antidepressant and go into a psilocybin experience? And there are studies, small studies, often open label, case series, whatever it may be, or data from you know retreat centers or places doing this work where they take a retrospective look, like Synthesis and Imperial has done a little of this. So you have these studies with sometimes with what may appear to be conflicting information. Like this study showed no impact of this set of SSRIs on the psilocybin experience, and in this study there was kind of maybe a blunting of the experience in some. And I don't view it as conflicting data necessarily, as just adding to the overall knowledge base that we are collectively keeping a pulse on as researchers and clinicians in this space, and translating into the guidelines with the best available knowledge now, right? Evidence-based practices now that, of course, will improve with clarity over time.
Yeah, that's a great point. And that's why a lot of times if you're looking through literature, there'll be like a review series where they looked at a number of things so that they could kind of get a larger picture than each study in and of itself, right? Like when we look at the totality of what's been studied, what are some of the patterns that are developing?
Yeah, and you bring up a good point too. As these cases and small studies, case series, clinical trials come out, there are more reviews and meta-analyses being done that look at the combination of data and can give, with more and more strength, a solid look at what's really happening. Because it is small numbers. Like if you're looking at psilocybin potential toxicity, right? There are animal studies showing that there's not really a known lethal dose of psilocybin, but it's theorized in animal models to be somewhere 500 to 1,000 times greater than a therapeutic dose, which would be impossible to consume by eating mushrooms. To have like 6,000 milligrams of psilocybin chemical compound itself instead of, say, 25 milligrams. But in the literature, there is like one reported death that's thought to be related to psilocybin. It was in a very medically compromised individual, someone like a 24-year-old post heart transplant. This is a 10-year-old case report who had a lot of comorbidities, and psilocybin was not the only medication on board. So those kind of things we learn from, and help shine a light on some of these guidelines as well, considering these rare events and worst case scenarios that all this data collectively makes up the best we know now, which I'm really happy with how the field has progressed and our understanding of these medicines to date, even though there's a long way to go.
Yeah, absolutely. And I think you brought up a great point with that, like you said, the example of the gentleman who had passed away after using psilocybin, and that wasn't the only medicine on board. When we talk about managing medical risk for patients undergoing psilocybin therapy, we are not saying that if, you and your doctor go in and you go through this risk assessment and they say, yeah, it seems like you're safe to do psilocybin. That doctor is not saying you are safe to do psilocybin and combine it with alcohol and LSD and then do it dehydrated. And like it's literally like they are saying that psilocybin therapy in and of itself alone has a certain risk for you. But I think that's a good point, is that anytime you start combining other things and other scenarios, then that whole situation can change. And so I think that's just something to put a fine point on, because this course was designed for the patients who are especially going into like one of these psilocybin therapy centers in Oregon, where they will be monitored, where they are taking, as far as they know, hopefully going in just psilocybin. And so speaking of that, I wanted to, in the course, we had a number of sections. And one of the first things that we covered was, what are some of the general indications for psilocybin? And so I know I've had a number of episodes where I talk about, with each of the researchers, but if you could just kind of give a very general overview of some of the most common indications that people may be seeking. By the way, just the caveat here, the asterisk, people in Oregon can go get psilocybin therapy for any reason they want. They don't need a medical indication. However, what are some of the medical indications that have been studied and psilocybin is showing to be effective for?
Yeah. So the first that comes to mind, of course, is major depressive disorder, both MDD itself and treatment-resistant depression, which is basically major depressive disorder that hasn't been responsive to 2 or more antidepressants. It's what Spravato or esketamine got approved for. It's what TMS is mostly used for, and what psilocybin, if FDA approved in the coming years, will likely be indicated for as its first indication, depression of some kind. But that's not even where it started in terms of studies. And I like to filter it because there have been a lot of registered clinical trials of psilocybin, but I like to filter it by like completed randomized clinical trials, which also include like end-of-life anxiety, the great work out of Hopkins, or similarly, advanced stage cancer-related anxiety. And there have been a number of studies leading up to these formal clinical trials being done on the FDA pathway on depression, major depressive disorder, treatment-resistant depression. There is, of course, the smoking cessation work done with psilocybin, and to my knowledge, the first modern NIH or U.S. government-funded grant of psychedelics in this wave of the Renaissance. Psilocybin for alcohol dependence had an exciting splash in recent months, but those are the main ones. And then I would consider the other kind of smaller pilot studies like psilocybin for OCD and psilocybin for eating disorders, where there's some preliminary data, being up and coming indications that look promising.
Yeah, just a plug. The first time Dr. Robison was on the podcast was about psychedelics for eating disorders years ago. So if that just piqued your interest, rewind and go check out that episode.
Yeah, I'll have to go look, because that was a couple of years is a long time ago in this field, isn't it?
That's true.
And back then, I don't know if we talked about this, but the psilocybin trials were more in the planning and regulatory and study design phases for eating disorders. But having just given a talk on psychedelics and eating disorders last week for the Psychedelic Association of Canada, and with our friend Pam Kriskow moderating, I was able to present real data coming off of several of these studies since then. So yeah, that's an example of how the work is being done. The evidence is rolling out of the clinics and research labs, and all the other sources we draw from, and it's exciting to keep tabs on.
What I just heard is you volunteering to do a follow-up episode. Is that what I got out of that, Reid? We're going to do a follow-up on the psychedelics for eating disorders. What we now know in the past 2 years.
It's a passion project and topic for me, so always happy to talk about it.
Perfect. Looking forward to it. Okay. Now we talked a little bit about the indications. Before we get to the contraindications, if you could indulge let's say the nerd core segment and talk a little bit about psilocybin pharmacokinetics. How does it work in our body?
Yeah. So after you take psilocybin orally, it loses a phosphate group somehow, is converted to psilocin in the acidic environment of the stomach, or by alkaline phosphatase in the intestine, kidneys. And then, so psilocybin is really considered a prodrug for psilocin. It's actually why have you heard of the lemon tech method?
Mm-hmm.
People sometimes do You might read about this on Reddit, even with some impressive technical details that people put on it. But the rationale behind that is accelerating the conversion of psilocybin to psilocin by lemon juice before even consumption. That's, of course, not relevant to the clinic work, but I just pointed out because it's showing that psilocin is really what is acting in the brain and the body, and so we look at the metabolism of psilocin and the half-life of psilocin to really get a feel for effects, even though it's psilocybin that's consumed, and that's the dose we're talking about when we say 25 milligrams of psilocybin, synthetic or naturally derived. It's that's mostly converted to psilocin and then distributed through the body, more than even the volume of water. It goes into the tissues. It goes in. It's metabolized mostly by the kidneys, but not all. And then as it crosses the blood-brain barrier, this psilocin gets to do its thing on serotonin and other receptors. And we talk about 5-HT2A the most, but there's activity in other serotonin receptors, even some mild dopamine activity, and there's the whole neuroplastogenic effects through mTOR and other pathways, enhancing the formation of neuron connections, new neuron growth, and then of course the physiologic effects that happen as a result of psilocybin and this 5-HT2A and other receptor activity.
Thank you for covering that. And that's something that will lead into our next question, which is, like you said, some patients may come in on other medications, and then it's a consideration for the provider, physician, whoever is doing this risk assessment to decide whether or not those medications will interfere. And so can you talk a little bit about like the medication interactions that people should look out for on a general scale?
Sure. And by kind of historical background, it's interesting to look back at, 75 years ago, or it was Albert Hoffman who figured out the chemical structure of psilocybin after, folks had made the trek down to Maria Sabina, and there was the Time Life magazine cover about that voyage. There was a lot to learn about what this thing was, including what's the chemical structure and how does it work. But in some of the studies over the past few decades, there's this research chemical called ketenserin that if you give it before psilocybin treatment, it blocks most of the effects. Depending on the dose of this kind of antagonizing medicine and the dose of psilocybin, you can essentially prevent a trip. And so there are some studies that have observed a similar, less dramatic phenomenon with certain antipsychotics like thorazine or chlorpromazine. In fact, this was in my eating disorder talk the other week, but there was a case report published back in the 50s of IV psilocybin given to a woman with anorexia in a hospital in Paris. And this is the first psilocybin in a medical setting study I'm aware of. And the first time they gave it, her effects were minimal. She didn't appear to be having a psychedelic experience much at all, except a couple hours later, she said, "Whoa, I just saw a choir of angels singing." And this was kind of profound. And they're like, "Oh, wait a second. There is something happening." So they took her off thorazine and repeated it again in a week or two, and she had an even bigger experience. So yeah, that's one category of things to be aware of as antipsychotics.
Very interesting. And then what about, I think, so large of a percentage of the US population is on an SSRI.
Yeah, and that's going to be much more common. There are more modern studies of like Haldol and Risperdal also blocking the trip, by the way. And then on the way to SSRIs, there are some interesting things you find, like Boost Bar or Boostbarone, the anxiety medicine, works on kind of a different pathway than SSRIs, but still serotonergic. And it increased the psychedelic experience.
Interesting.
In this small study of like 20 people a few years ago. SSRIs are more unpredictable. Like, I think the biggest study I'm aware of was a 2022 study by Becker and colleagues, where this was an RCT with I think 20 something healthy participants who were on it was to examine Lexapro and psilocybin and the interaction. So they were pre-treated with Lexapro for a couple weeks, so 10 milligrams per week, 20 milligrams per week, and then they got and then they got 25 milligrams of psilocybin in the study. And the study found that pre-treating or having Lexapro on board, or escitalopram, reduced some of the ego disintegration effects, is how they called it. And it also reduced some of the anxiety, but it didn't reduce euphoria or another part of the mystical experience, oceanic boundlessness, for example, or depersonalization. So it's really fascinating and highlights that there's a lot to learn, and it's a little bit unpredictable. And some people, I think, anecdotally would say that their SSRI interfered with their trip or diminished the experience, and others would say it did not. Yeah.
Interesting. So, whereas we know, okay, it may or may not diminish the experience, is there any danger that would make it a contraindication?
There's the serotonin syndrome risk that is, somewhere in between this kind of theoretical and real world risk. I say that because it's not a common occurrence. And as a psychiatrist, having prescribed a lot of serotonergic compounds and having done a lot of work with these psychedelics, including, working overseas with ayahuasca clinically and things, I've had to get pretty concrete about what is this risk. And So the general idea is that if you have too many kind of serotonin promoting, releasing drugs on board, you should be worried about serotonin syndrome, which can be a scary thing to encounter as a clinician, and not something you want to have as an individual. Treatable but urgent, and so that's another way the SSRIs come up in terms of what are you on, what dose, and are there other serotonergic medications on board, even things you might not naturally lump in that category, like the anti-nausea medicine Zofran or ondansetron, for example.
Yeah, I hadn't thought about that one. And for everybody out there listening, just to clarify, Dr. Robison wrote the vast majority of our course, but also the contribution in the more pharmacologic section and the drug-drug interactions. We had the contribution of Dr. Ben Malcolm, who is the spirit pharmacist. I know whenever he's on the podcast, people listen to that like crazy. So just want to give a shout out to Dr. Malcolm for his work on the course. One other thing that we cover in the course that I'm just going to throw this in here is we specifically did cover what is going on in Oregon, because this, while we'd love for clinicians across the country/world to take this, and I say country because our CME and CE will only apply to American clinicians, but anybody can take it. We really thought that this is actually emergent for the clinicians in Oregon, because primary care physicians across the state are going to have patients showing up asking these questions, and those clinicians may even wonder what is going on with Oregon. Like, what, if they're not in the psychedelic world keeping up, they might just wonder what does this psilocybin program look like? What if I say to the patient, yes, you are safe, what are they going to undergo? So just for anybody who's considering taking the course, that's also a section. It talks about who in Oregon can take it. What are some of the requisites? What does it look like? Even though Oregon has not, I don't think the first center has opened its doors for any patients officially. I know it will look like a lot of different things. There may be centers where only microdosing is happening, and there are centers where significantly larger doses are happening. But I just wanted to throw out that we did have an entire section in there about that. Now, Dr. Robison, if you could cover just some of the more interesting, the course goes into a lot of specifics on, let's say, both relative and more absolute contraindications. And for the non-medical set out there, a contraindication is something that says, if you have this condition, you should not do it's not advisable to do this therapy. And like I said, there's absolute and relative. Relative might mean, well, if you have this certain condition, let's take some extra precautions, or let's really dive deeper into your history to see if you should do that. And then there's some absolutes that say like, absolutely no way that a person should do this. I think a good example of that, an absolute contraindication, would be, we've had episodes on ibogaine. If somebody has a certain QT prolongation, ibogaine is absolutely contraindicated. So, Reid, if you could tell us just some of maybe the more interesting or less well-known contraindications for psilocybin therapy.
Yeah, so we talked about the psychosis one, so I'll mostly skip over that. But it's an example of where there's several papers, citable references showing this potential concern of unearthing or exacerbating mania or psychosis. So and I would say the same thing about um, things like a present suicide risk needs to be carefully evaluated, um, even though, and especially because these medicines are being explored for severe depression, where there's a suicide risk along with it. We need to be extra careful. We don't have a clear cut like risk stratification equation there, but it's an example of where there needs to be a very careful consent process and good supports on board, both in the clinic or treatment setting and outside of it. But to answer your question on kind of potential absolute contraindications, pregnancy, we don't know enough about psilocybin other than it can pass on through, and including through breast milk. But the QT prolongation you mentioned is also a good example that shows up with a lot of psychiatric medications. As far as I know from the literature, there's a little bit of QT prolongation that can occur with psilocybin. There's a little bit with Lexapro as well. So when you go into these, you have your data from the literature, like that this given medicine may prolong QT by this amount on average. You don't know what's going to happen in your patient, but that good practice guidelines can be so helpful in saying, okay, that's easy. I check QT before, and if it's beyond my comfort zone or this kind of consensus recommendation of, say, a QTC of 450, then let's not proceed. I'll point out that ibogaine presents much more of a concern with QT prolongation than psilocybin, but it's something that's being watched in the psilocybin data carefully.
I appreciate that. And for everybody out there who we just lost, QT prolongation is, when we say prolongation, you've seen the EKGs, you've seen, like, at least on medical shows, there's that thing next to the patient that's like beep, beep, and it's making this up and down. That prolongation is talking about that there's an elongated period on that EKG readout. One other thing that I would love to have you discuss that I think kind of gets overlooked a lot in the microdosing world, can you talk about the potential effects on heart valves?
Yeah, so that's an interesting one. There's been a bit of it's been a bit of a debate, I'd say, on psilocybin and cardiac considerations over the past several months because of two things. We talked about the transient increases in blood pressure, heart rate. We talked about the slight prolongation, but there are some other concerns about certain, I guess, to simplify, serotonergic receptors that are targeted by psilocybin and heart valve. Not a not a clear-cut consensus on who should not get and what types. And at this stage of knowledge of psychopharmacology and medical risk, it's best to just land on a place of saying that psilocybin may have some extra adverse events in those with heart valve abnormalities, and we need to understand that better, but also proceed with great caution in the meantime. But I know it's something you've been asked about a lot as well, Lynn Marie. Do you have anything you think is relevant to add?
Oh, on the heart valve issue?
Yeah.
No, I still go back to worth noting and keeping on the radar, don't have enough data. But I think that also it's just worth continuing to bring up, because I think a lot of times we blanket statement with things like microdosing is safe.
Yeah.
And that's just what concerns me, is that like we don't know enough. We don't have actual data on what the valves of a microdoser looks like. That's not, we don't really know. And so with those who have any kind of cardiac condition, I would say let's not just assume it is safe. Let's take a closer look, at least, discuss it with your cardiologist. And then, asterisk again, it is a privileged statement to be able to say, I can discuss psilocybin with my cardiologist, right? There are some patients who that would bring them in certain types
Yeah.
of trouble. And so that's why we are trying to, and I'm going to let that lead into the other reason that we put this course together was, one, to educate the clinicians in, let's say, starting with Oregon, but Colorado we know is next. But we wanted patients who may be more medically complicated to be able to find clinicians with whom they could, one, safely speak about their desired psilocybin use. And also, like you said, they may be going to do psilocybin somewhere else in the world. So that's why it's not just Oregon clinicians that we think this is for. Anybody in the US who wants to go to their clinician and say, hey, maybe I'm going to go do it where it's legal, I would like to know if it's medically safe for me, right? They're not even doing necessarily an illegal thing. But we still want them to go to a clinician, one, who is they're going to feel safe discussing that with, but two, we want to send them to a clinician who knows psilocybin, right? That's why we made the course. We want to educate clinicians on the indications, what that means, what conditions it may be helpful for, the contraindications, like we talked about, what things like, pregnancy, we don't know enough about to say yes, so we'd say conservatively no at this point, medication interactions. And so with our course, which is also called Managing Medical Risk in Patients Seeking Psilocybin Therapy, if a practitioner takes our course and then they choose to, they can be added to a database. And it's the database of psilocybin informed clinicians that we have started. And once we have a critical mass, we will publish that so that patients can find a clinician in their area who they could go see, and that patient will know that at least this doctor, PA, nurse practitioner, whoever, has a baseline amount of knowledge that they can answer these questions, right? I mean, and it may be that like the clinician thinks like, oh, your cardiac situation is a little bit more complicated and they can refer on, but we want patients to be able to know where they can go and see a doctor or other practitioner who's going to have this knowledge. And like you said before, since this is such an evolving area, anybody who takes our course, we insist that they also join the Psychedelic Medicine Association, because we want to keep, once you're in our database, we don't want your knowledge to stop with our course. Because like you said, like once this bipolar study comes out, that might change what we think of as a contraindication. So we're going to send out those updates to our members like we do every month. We want everybody in our database to get those updates so that their knowledge can continue to evolve as the research does. So that's a big point that I'm glad we got into, which is we wanted this course to educate the clinicians, and then likewise we wanted patients to be able to find the clinicians who have been educated. And so that's a big drive behind this. Reid, is there anything that I have left off that just in general you think considerations about, medical risk with psilocybin or psychiatric risk, any of the above, any topics that we should leave our listeners with?
Well, we could, of course, talk about this for many hours, going into the little nuances. Like we just glanced over the heart valve debate, and that could be a topic of its own. This whole 5-HT2B receptor, what happened in my studies with to make this theoretic concern, and how in humans it's not really panning out to be that relevant, but still, in the absence of clear-cut, absolute, clinical evidence, we proceed with caution. But um, I think the last thing I would highlight is just the psychological risks are worth really keeping tabs on, because there's a lot of enthusiasm in the space. In fact, I went to a talk the other day at the Psychedelic Medicine conference in Denver by MAPS, a talk by David Yaden on his paper with Roland Griffiths on the hype cycle and the bursting of the hype bubble. And he made some really good points of the need to balance all these enthusiastic, positive claims with whatever we know to the contrary in the literature, like we're talking about here in general. But psychological risks are non-trivial, including the risk of a difficult experience, something that may even need some mental health treatment afterwards, something that may be meaningful, non-trivial for the individual for a while, and can coexist with the mystical experience, and having the most meaningful experience of your life can coexist with having one of the most difficult.
Absolutely. I'm so glad you brought that up. Thank you for sharing that. We have an episode that will be coming up. I think we'll release it right after. But I have Jules Evans is coming on talking about the Challenging Experiences Project, and so we have a whole
Oh,
episode
cool.
coming up about when, like you said, it could be them simultaneously. These are not mutually exclusive. The most incredible experience, and you could suffer some psychological consequences from things that happen in these experiences. And so you're right. Like, we do need to keep that, these are very powerful tools. Keep that in mind always, that we, clinicians especially, our oath is first do no harm. And so
Yeah.
what we can do to, and this, speaking of a whole nother episode, we can do an entire 10 more episodes on how you would do an actual informed consent for this, because how can you inform somebody about what's going to happen to them in psilocybin therapy when, as you said, there is oceanic boundless list, that there is absolutely no way you can probably adequately explain. The ineffability literally means can't explain it. So how you inform consent somebody on that is going to be really difficult. But yeah, that's, at least informed somebody about the risks. I think that's the main thing. We may not be able to tell them all the things that they may encounter in their journey, but to be able to say, this is not without risk. Medically, here are some risks, but also psychologically, there are these other risks. And I think that, that's incredibly important for people to keep in mind, especially like you said, with the hype cycle. So thank you. I think that is a brilliant place to end this. Before I tell everybody where to find this course, please, Reid, tell everybody where to find you and your work.
As you mentioned initially, I'm with numinous.com, as the chief clinical officer. And we have clinics in Utah, Arizona, and across Canada, and research sites in Utah and Arizona. You can also find me at reidrobison.com, where I've kind of collected some resources for people as well.
Well, I want to thank you for coming on, and for your years of dedication to the Psychedelic Medicine Association, and for your extreme amount of dedication, you and your son, to helping create this course. Very meaningful to me. I know we had barely met when you said yes to this, so it was a massive honor that you jumped on board so readily. And thank you for coming on and sharing today. So everybody out there, this is a CME CE accredited course for. If I tell you the number of hours, I'm supposed to read this other paragraph, but just know it is not. It is more than 1 hour. I will tell you.
Mm-hmm.
So I'm going to get around that. But if you go to psychedelicmedicineassociation.org, you can find the course. Like I said, if you take the course, it comes with a Psychedelic Medicine Association membership if you don't already have one. And we would be very stoked to have you in the Psychedelic Medicine Association as well. We have a monthly webinar every month with experts like Reid. Reid came on when we did an entire deep dive into psychedelics for eating disorders. We have panelists of just the world's leading experts. You get to be one-on-one asking them questions in these webinars. Every month we send you the latest in research. Like when the bipolar study comes out, you will find out that month instantly. We have a great online community. We have over 1,100 members, 100 organizations. It's just, I am 100% biased, but I think it's a great place to come meet like-minded folks. I think, Reid, you had even in the first webinar you came on, you told me that you met somebody in that webinar from the association who became a research assistant.
Yeah, postdoc or a grad student. We published several papers together. Thank you again for that beautiful connection.
Well, I was glad you told me, because that's exactly the kind of thing that I want to happen in our webinars and in our community. So the fact that it happened right off the bat made me, and with with our treasured board members, made me very happy. So please head on over to psychedelicmedicineassociation.org. Join us. If you want to just join us and take the course, then you can be featured in our psilocybin informed clinicians directory that comes out. All of the above is just geared toward harm reduction, safety, because we want, like you said, we can't manage everything, but if we could do our best to manage the medical risk, that is going to set patients up for the most success in this treatment. Reid, thanks again for coming on and sharing with us today.
Thanks for having me. Always a pleasure.
Thanks again. And for everybody else out there, until next time. Thanks so much for listening to the Psychedelic Medicine Podcast. If you enjoyed what you heard, please leave a rating or review, as it helps others find the show. And if you'd like to learn more, you can find the show notes at plantmedicine.org/podcast, and there's information for clinicians at psychedelicmedicineassociation.org. Our incredible music was by the one and only Porangi. We'll see you next time.